Before you schedule that colonoscopy your doctor says is mandatory, I need you to hear what happened to Robert. Robert was 74, active, healthy, played golf twice a week, no symptoms whatsoever. His doctor insisted he needed a routine colonoscopy for preventive care. Mandatory at his age, they said. 3 days after the procedure, Robert was in the ICU with a perforated bowel. Emergency surgery. 6 weeks of recovery. He developed pneumonia in the hospital. 2 months later, he was dead. Not from colon cancer. From complications of a screening test he never needed. And here's what breaks my heart. The medical evidence shows Robert's story isn't rare. It's predictable. Because there are 3 tests that doctors routinely call mandatory after age 70 that major medical organizations have quietly changed their recommendations on. Acknowledging these tests often cause more harm than good in healthy seniors. I'm about to share medical evidence that will likely contradict everything your doctor has told you. Evidence from the most prestigious medical journals showing that refusing these 3 tests could literally add years to your life. But this information rarely reaches patients because these 3 tests generate over $40 billion annually for the healthcare system. Stay with me for the next 20 minutes because I'm going to show you exactly which 3 tests to refuse, the specific medical evidence supporting this decision, how to have this conversation with your doctor, and most importantly, what you should focus on instead that actually extends healthy life after 70. If you're over 70, approaching 70, or have parents in this age range, screenshot this information. Share it, because by the end of this video, you'll understand why sometimes the most important thing you can say to your doctor is no. I've reviewed thousands of cases, and I've watched a pattern emerge that the medical establishment doesn't want to discuss openly. The pattern is this. Healthy seniors who refuse aggressive screening after 70 consistently live longer, more comfortable lives than those who submit to every test their doctors recommend. That statement should shock you. It certainly shocked me when I first recognized it. But once you understand the medical evidence, it becomes obvious. Here's what we're covering in this video. First, the fundamental shift that happens to your body after 70 that changes the entire risk-benefit calculation for screening tests. Second, the 3 specific tests you should seriously consider refusing, with the exact medical evidence supporting this decision. Third, the financial incentives driving doctors to continue ordering these tests despite the evidence. Fourth, how to have this conversation with your doctor without damaging the relationship. And finally, what you should focus on instead that actually improves longevity after 70. Before we dive in, if this information helps you or someone you love avoid unnecessary medical harm, hit that subscribe button. This channel exists to share evidence-based medicine that prioritizes your well-being over medical profits. And leave a comment telling me your age and whether your doctor has pushed any of these tests on you. I read every comment, and your experiences help others make informed decisions. Now let's start with the medical reality that changes everything after 70. Here's what medical school doesn't adequately teach doctors, and what most doctors never discuss with their elderly patients. Screening tests are designed based on a specific mathematical calculation. The calculation weighs the probability of finding disease, the likelihood that finding it early will change outcomes, against the risks of the screening procedure itself and any follow-up interventions. This calculation works beautifully for 50-year-olds. It often fails catastrophically for 75-year-olds. Here's why. After age 70, 3 critical factors shift dramatically. Factor 1. Your life expectancy changes. At 50, you have an average of 30 more years. At 75, you have an average of 11 more years. This matters because most cancer screening tests detect are slow-growing. They take 10 to 15 years to become life-threatening. So finding them at 75 often means finding a disease that will never actually threaten your life because something else will get you first. Factor 2. Your body's ability to tolerate procedures declines. Anesthesia becomes riskier. Healing takes longer. Complications that a 50-year-old would recover from in days can hospitalize a 75-year-old for weeks and trigger a cascade of problems: pneumonia, delirium, falls, functional decline. Factor 3. The natural pace of disease progression slows. Cancers in elderly patients grow more slowly than the same cancers in younger patients. Your aging immune system, ironically, actually slows cancer growth. This is well documented in medical literature, but rarely discussed. Put these 3 factors together, and you get a shocking conclusion. After 70, Many screening tests are more likely to harm you through complications and overtreatment than to extend your healthy life by detecting disease. But here's where it gets worse. Doctors are financially incentivized to ignore this reality. Let me show you how. The average colonoscopy generates $3,500 in revenue. If a doctor screens just 10 elderly patients per week, that's $1.8 million annually. The average PSA test cascade, from test to biopsy to treatment, generates $25,000 to $50,000 per patient. Cardiac stress testing leading to catheterization and stenting generates $40,000 to $60,000 per patient. Now you understand why your doctor insists these tests are mandatory despite medical evidence increasingly questioning their value in healthy seniors. Let me show you the specific evidence for each test. Test number 1 to seriously consider refusing: routine colonoscopy screening after age 75. Let me be crystal clear about what I'm saying and what I'm not saying. If you have symptoms, bleeding, changes in bowel habits, unexplained weight loss, then diagnostic colonoscopy may be absolutely appropriate. But routine screening when you feel fine, when you've had normal colonoscopies previously, that's what the evidence increasingly argues against after 75. Here's what the U.S. Preventive Services Task Force, the gold standard for screening recommendations, now says. They explicitly recommend against routine colonoscopy screening after age 75 for people who've had normal previous screenings. Not maybe. Not use clinical judgment. They say don't do it. But most doctors ignore this recommendation. Why? Follow the money. Gastroenterologists make their living performing colonoscopies. The procedure is extremely profitable. Each one takes 20 to 30 minutes and generates $3,000 to $5,000. A gastroenterologist can easily perform 15 to 20 per week. You can do the math. Now here's what they don't emphasize when they're scheduling you for that mandatory colonoscopy. The complication rate increases dramatically after 70. Bowel perforation, the most serious complication, occurs in 1 in 300 procedures for seniors compared to 1 in 1,000 for younger patients. That's triple the risk. A perforated bowel requires emergency surgery, weeks of hospitalization, and carries a mortality rate of 5 to 10%. But perforation isn't the only risk. Cardiovascular complications from sedation increase significantly after 70. The bowel preparation itself, that horrible clean-out you have to do, can cause dangerous dehydration and electrolyte imbalances. I've seen seniors end up in the ER with heart arrhythmias, severe dehydration, and falls related to the prep, never even making it to the procedure. Now let's look at the benefit side of the equation. What are you actually preventing by getting that colonoscopy? Here's the medical reality. Colon cancer is slow-growing, extremely slow-growing. From the time a polyp forms to the time it becomes invasive cancer takes 10 to 15 years on average. If you're 75 and had a normal colonoscopy at 65 or 70, any new polyp that develops will take another 10 to 15 years to become dangerous. Statistically, you're far more likely to die from heart disease, stroke, pneumonia, or simply old age before that polyp ever threatens your life. But here's the most damning evidence. A landmark study published in JAMA Internal Medicine followed more than 50,000 seniors over age 75 for 10 years. Half continued routine colonoscopy screening. Half stopped screening. The results? Those who continued screening had no improvement in colon cancer mortality. None. Zero benefit. But they had significantly higher rates of hospitalization for complications from the procedures themselves. Let me repeat that because it's crucial. Continuing colonoscopy screening after 75 provided no benefit in preventing colon cancer death, but caused measurable harm through complications. Yet doctors continue pushing these procedures. And here's how they do it. They use fear. They'll say things like, colon cancer is the second leading cause of cancer death. We need to catch it early. You don't want to risk it. All technically true statements, but completely misleading for a healthy 75-year-old with previous normal screenings. The real question you should ask is this: Doctor, given my age and my previous normal colonoscopies, what is the actual probability that I will develop colon cancer that will threaten my life in my remaining years versus the probability I'll have a complication from the colonoscopy itself? Most doctors won't answer that question honestly because the data doesn't support continuing screening. Let me give you a real example. A patient named Dorothy came to me at age 77. She'd had normal colonoscopies at 55, 65, and 75. Her new gastroenterologist was pushing for another one, calling it standard of care. I showed her the U.S. Preventive Services Task Force recommendation against it. We discussed that her risk of a complication from the procedure exceeded her risk of developing life-threatening colon cancer in her remaining years. She decided to refuse. That was 6 years ago. Dorothy is now 83, healthy, active, and has never developed colon cancer. Meanwhile, 2 of her friends who did get colonoscopies at her age ended up with complications. One hospitalized for a week with dehydration from the prep, another with a perforation requiring surgery. This isn't cherry-picking. This is the pattern the data shows consistently. Test number 2 to seriously consider refusing. PSA screening for prostate cancer after age 70. This one makes some doctors absolutely furious when I discuss it. But the evidence is overwhelming and the medical consensus is clear. Here's what they don't tell you about prostate cancer. Most men over 70 have it. Autopsy studies, where they examine the prostates of men who died from other causes, show that 60 to 70% of men over 70 have prostate cancer cells. They died with prostate cancer, not from it. These cancers were growing so slowly they never caused symptoms, never threatened life. This is the fundamental problem with PSA screening after 70. It finds cancers that would never have hurt you, and then the medical system pressures you into treating them. Let me walk you through the typical cascade of harm that starts with a simple PSA test. You're 72. Feel great. No urinary symptoms. Your doctor orders a PSA test as part of routine blood work. It comes back elevated. Not dramatically high, just above the threshold. Now your doctor refers you to a urologist. The urologist tells you need a prostate biopsy. Nobody mentions that the biopsy itself has a 2 to 3% risk of life-threatening infection. That risk is even higher in elderly men. I've seen patients end up septic in the ICU from prostate biopsies. Some have died from the infection. But let's say you survive the biopsy. It finds cancer, which it probably will, because remember, most men your age have prostate cancer cells. The pathology report shows a Gleason score of 6 or 7. Not aggressive, but cancer nonetheless. Now you're sitting in the urologist's office being told you need treatment. Surgery or radiation. Maybe both. The doctor uses fear. Cancer. We need to get it out. We need to treat it aggressively. Nobody mentions that the cancer probably would never have threatened your life. Nobody shows you the studies demonstrating that men with low-grade prostate cancer who choose active surveillance live just as long as men who undergo aggressive treatment. So you get the surgery or the radiation, and now you're dealing with the consequences. Permanent urinary incontinence occurs in 20 to 30% of men after prostate surgery. You're wearing pads for the rest of your life. Erectile dysfunction occurs in 40 to 60%. Your sex life is over. And some men develop both urinary and bowel complications that severely impact quality of life. All to treat a cancer that would likely never have killed you. Here's the research that proves this. The European randomized study of screening for prostate cancer followed 162,000 men for 13 years. For men over 70, PSA screening did not reduce death from prostate cancer. Read that again. It did not reduce death from prostate cancer, but it did lead to massive increases in biopsies, surgeries, and radiation treatments, all with serious side effects. Another study published in the New England Journal of Medicine compared aggressive treatment versus active surveillance for low-grade prostate cancer in men over 65. After 10 years, there was no difference in mortality. None. But huge differences in quality of life, with treated men suffering significantly higher rates of incontinence and erectile dysfunction. This is why every major medical organization, the U.S. Preventive Services Task Force, the American Cancer Society, even the American Urological Association, now recommend against routine PSA screening after age 70 unless you have symptoms or strong family history. But doctors continue ordering these tests. Why? Because the treatment cascade is incredibly profitable. From PSA test to biopsy to surgery or radiation, each patient generates $25,000 to $50,000 in revenue. Urologists and radiation oncologists make their living treating prostate cancer. They have powerful financial incentives to keep finding it and treating it, even when the medical evidence says treatment doesn't help. Let me share another real case. A patient named Frank came to me at 74. He felt great. His previous doctor had ordered a PSA test without even discussing it with him. It came back slightly elevated. He was referred to a urologist who immediately scheduled a biopsy. Frank came to me for a second opinion. I showed him the medical evidence. We discussed that given his age, his lack of symptoms, and the slow-growing nature of prostate cancer, he was far more likely to be harmed by the biopsy and subsequent treatment cascade than to benefit from finding a cancer that would threaten his life. He decided to refuse further testing. That was 7 years ago. Frank is now 81. Still feels great. No urinary symptoms. No cancer symptoms. He never had that biopsy. He avoided the entire cascade of harm. Meanwhile, 3 of his friends in their 70s went through the full treatment process. All 3 now have permanent incontinence. 2 have complete erectile dysfunction. 1 developed serious complications from radiation requiring additional surgeries. All 3 were told they had to treat their cancer aggressively. All 3 now regret it, wishing they'd chosen active surveillance or refused screening altogether. This is the reality of PSA screening after 70. It finds cancers that don't need to be found and leads to treatments that don't need to happen, causing permanent harm to quality of life without extending life. The question you need to ask your doctor is this: if you find prostate cancer in me at my age, what are the actual chances it will threaten my life and my remaining years versus the chances that treating it will cause permanent complications that reduce my quality of life? Most doctors won't answer that honestly because the data doesn't support aggressive screening and treatment. Test number 3 to seriously consider refusing: cardiac stress testing when you have no symptoms. This is the test that sounds so reasonable. Let's just check your heart. Make sure everything's okay. It's preventive care. Better to catch problems early. But here's what happens in reality. Stress testing in asymptomatic seniors leads to a cascade of unnecessary interventions that often cause more harm than benefit. Let me walk you through the typical scenario. You're 73. No chest pain. No shortness of breath. You can walk, climb stairs, do your normal activities without problems. But your doctor says, let's get a stress test just to make sure your heart is okay. It's standard at your age. You go for the test. They hook you up to monitors, put you on a treadmill, or inject you with medication to stress your heart. And here's the first problem. The test itself can trigger heart attacks in elderly patients. It's designed to push your heart to maximum capacity. Sometimes that's the straw that breaks the camel's back. But let's say you survive the test without incident. The results come back abnormal. Not severely abnormal, just some changes that concern the cardiologist. Now you're told you need a cardiac catheterization to see what's going on. This is an invasive procedure where they thread a catheter through your blood vessels into your heart. It carries risks: bleeding, infection, stroke, kidney damage from the contrast dye, and yes, even death. The catheterization shows a 40 to 50% blockage in one of your coronary arteries. Not severe, not causing symptoms. But the cardiologist says, we should put in a stent to prevent a future heart attack. Nobody mentions that for stable, asymptomatic blockages, stents don't prevent heart attacks. This isn't controversial. This is established medical fact proven by multiple large randomized trials. The COURAGE trial compared stents plus medication versus medication alone for stable coronary disease. Result: no difference in heart attacks or death. The ORBITA trial showed that stents for stable angina provided no benefit over placebo. Even when patients thought they were getting better, objective measurements showed no improvement. But you get the stent anyway, and now you're on blood thinners for life. Aspirin and Plavix or similar medications. These dramatically increase your bleeding risk. Falls become more dangerous. Minor injuries can lead to serious bleeding. Some patients develop life-threatening gastrointestinal bleeding from the blood thinners. All because of a screening test you never needed that found a problem that didn't need fixing. Here's the research that proves this pattern. A study in JAMA Cardiology followed 10,000 seniors without cardiac symptoms. Half received routine stress testing. Half didn't. After 5 years, there was no difference in cardiac outcomes. No difference in heart attacks. No difference in cardiac death. But the group that received stress testing had significantly higher rates of complications from follow-up procedures, catheterizations, stent placements, bypass surgeries they didn't need. Another study analyzed Medicare data for 24,000 seniors. Those who had stress testing without symptoms ended up having 3 times as many cardiac procedures as those who didn't get tested. but they had no better survival. They just had more procedures, more complications, more hospitalizations. This is called the cascade effect. One test leads to another procedure, which leads to another intervention, each with its own risks, none improving outcomes, all generating revenue for the healthcare system. Let me share a specific example. A patient named Helen came to me at age 76. She walked 2 miles daily. Felt great. No symptoms. Her cardiologist wanted a stress test just to check things out. I asked Helen, "Do you have any chest pain, shortness of breath, or unusual fatigue?" She said no. I explained that stress testing in asymptomatic patients doesn't improve outcomes, but often leads to interventions with real risks. She decided to skip the test and focus on what actually prevents heart disease: daily exercise, Mediterranean diet, blood pressure control, and cholesterol management with medication. 6 years later, Helen is 82, still walking daily. No cardiac events, no procedures, no complications. Compare that to her neighbor Margaret, who had the stress test. It showed abnormalities, led to catheterization. They found a 45% blockage. Put in a stent to be safe. Margaret developed bleeding complications from blood thinners, had a serious fall requiring hospitalization, and now lives in fear of another fall because she knows any head injury could be catastrophic on blood thinners. Margaret's quality of life decreased significantly after that stress test. Did the stent help her? Almost certainly not. The medical evidence shows stents don't prevent heart attacks in stable, asymptomatic patients. But here's why doctors keep ordering these tests. A cardiologist who performs stress tests leading to catheterizations and stent placements can generate $40,000 to $60,000 per patient. Multiply that by dozens of patients per month, and you see why financial incentives override medical evidence. The question you need to ask your doctor is this: I have no symptoms. What evidence shows that stress testing in my situation will improve my cardiac outcomes versus exposing me to risks from the test itself and follow-up procedures? Most doctors can't answer that question with data because the data doesn't support routine screening in asymptomatic seniors. Now, if you do have symptoms, that's completely different. Chest pain, shortness of breath with exertion, unusual fatigue, those are appropriate reasons for diagnostic testing. But screening when you feel fine is what the evidence argues against. So if you're refusing these 3 tests, what should you focus on instead? This is the most important part of this video because refusing harmful screening is only half the equation. The other half is investing in interventions that actually extend healthy life after 70. Here's what the research consistently shows actually improves longevity and quality of life in seniors. Number 1, daily physical activity. Not intense exercise. Just walking 30 minutes daily reduces all-cause mortality by 30 to 40% in seniors. That's better than any screening test or medical procedure. Add strength training twice weekly and you reduce falls, maintain independence, and extend healthy life even further. Number 2, Mediterranean diet. The evidence is overwhelming. Seniors who follow a Mediterranean diet pattern, lots of vegetables, olive oil, fish, nuts, whole grains, live longer and have lower rates of heart disease, stroke, and dementia than those who don't. No screening test provides that benefit. Number 3, social engagement. Loneliness and social isolation increase mortality risk by 50% in seniors. More than smoking, more than obesity, maintaining friendships, staying involved in community activities, having regular social interaction extends life more than any medical test. Number 4, blood pressure control. If your blood pressure is elevated, treating it with medication prevents strokes and heart attacks. This is proven. This works. But it doesn't require aggressive screening tests. It just requires checking your blood pressure regularly and taking medication if needed. Number 5, cholesterol management. If you have high cholesterol or known heart disease, statin medications reduce cardiac events. Again, proven benefit. But this doesn't require stress tests. Just a simple blood test and appropriate medication. Number 6, staying up to date on vaccinations. Pneumonia vaccine, shingles vaccine, annual flu shots. These prevent serious infections that can be devastating in elderly patients. This is preventive care that actually works. Notice what's not on this list? Colonoscopies after 75, PSA screening after 70, stress tests without symptoms, because the evidence doesn't support them. Focus your energy and your medical care on the interventions that actually work. Exercise, nutrition, social connection, management of known conditions like blood pressure and cholesterol. These are the things that extend healthy life after 70. Refusing harmful screening tests isn't about avoiding medical care. It's about being selective and evidence-based, prioritizing quality of life over quantity of medical interventions. Let me leave you with this final thought. The medical system profits from testing, from procedures, from interventions. Your doctor may genuinely believe they're helping you by ordering these tests. But good intentions don't change the medical evidence. After 70, less aggressive medical care often leads to longer, healthier, more comfortable lives than the test everything, treat everything approach that's become standard. You have the right to refuse screening tests. You have the right to see the medical evidence. You have the right to prioritize quality of life over medical profits. If your doctor insists these tests are mandatory, ask them to show you the current recommendations from the U.S. Preventive Services Task Force. Ask them to explain why they're ignoring the medical evidence. Ask them to quantify your actual risk versus benefit given your specific age and health status. Most doctors won't have good answers because they're operating on outdated protocols and financial incentives, not current medical evidence. Take control of your health by refusing tests that harm more than help. Focus on the interventions that actually work. And live your remaining years with vitality and comfort, not with complications from procedures you never needed. If this information helped you, share this video with someone who needs to hear it. Subscribe for more evidence-based medicine that prioritizes your well-being over medical profits. And leave a comment telling me, has your doctor pushed any of these tests on you? What did you decide? Remember, after 70, sometimes the most important thing you can say to your doctor is no, because that one word might just add years to your life.